Hello and good afternoon to everyone. I am Dr. Todd Morgan, and it's my privilege to be in front of you today. I am an expert in oral appliance therapy for sleep apnea, and the title of my talk is Oral Appliances for Treatment of OSA, Controversies, Outcomes, and Payer. Okay, so I want to broach all of the subjects with you today in the 30-minute talk I have. Certainly, controversies exist around oral appliances, and I have to say primarily because of outcomes. We don't have great outcomes with oral appliances. I'm going to go through a little bit of the literature today, but we get folks about 75 or 80% better than they were with sleep disorder breathing, but certainly not as good as CPAP. So for about the last 10 years, at least my first 10 years, I was considered a rescue operation for folks that couldn't use CPAP. So last resort, let's go see Todd Morgan. Maybe he can help you. Sadly, the other controversy is like dentists cowboying and circumventing the physician on diagnosis and treatment, overstepping their scope of practice, if you ask my opinion, and bad mouthing CPAP, which I think is wrong. CPAP is wonderful, and it has a wonderful place for lots of patients. Nowadays, we've got payers and physicians sort of putting a little pressure on dentists to muster up and be part of the team. So the key to our existence, my dental sleep disorder breathing practice, is cooperation and collaboration with physician. And that's where I want to be. My invited talk will cover a range of issues, including treatment strategies, patient selection for oral appliances, and payer coverages. I hope I can get that. Let's start with a question for many of you. What are oral appliances, and how do they work? Well, the answer is that oral appliances have been around a long time, almost as long as CPAP, and they get patients better. And in my last 25 years of practice, I've been trying to figure out who they're going to help better than others. We have some patients that respond beautifully to an oral appliance and chinning the patient while they're sleeping. And all of you know how to chin a patient after anesthesia, right? But holding their jaw in a hammock at night works most of the time, but not every time. So it's very frustrating sometimes. So what phenotype is the ones that could use oral appliances? That's kind of the focus of the talk today. So I have no disclosures, financial issues, or conflicts of interest today. So a collaborative effort. This slide, where does the dentist oral appliance therapy fit in with the MD? And being a pioneer in the field, I would say, I would hear, what are you going to do with that hunk of plastic? And why does it cost so much? And I'm like, well, if I made your patient a denture, there's a lot of work that goes into fitting something onto the teeth and protecting the dentition, the TMJ, and all these things that I think about every time I treat a patient. So a reasonable treatment option for patients, yes. What's the relationship between the MD and the DDS? Well, it should be one of cooperation and respect. Patient selection is what I've worked on for 25 years. And insurance coverage has come around, over the last few years as well. So if we go into a little bit of the research, well, first of all, let me back up because, I got kicked around a lot in my early days, and it hurt. And, it wasn't that the doctor didn't respect me. It was just that, like, show me some research and some basis for oral appliances working well. And so there's lots of folks, notable people that have worked on oral appliance therapy and showing that it works. And with the advent of new imaging with cone beam imaging, we're a lot better at predicting who it's going to work for. Now, let me move on. The sleep research overall, we're only a tiny sliver of what's been done in sleep research. OSA, we're part of that, but oral appliances have not really been lauded as having enough research. So I apologize, but we are effective. And actually, we published a Sentinel article early in the 90s. So let me describe what you see here. This is an older patient, obviously, wearing a simple two-piece night guard, if you will, glued together in a forward position of the jaw. Okay, essentially a double night guard that held the jaw forward. Okay, that's what the slide says. And so I did this for, actually this is the early days. I did this for a long time. And we actually published a very early seminal article in Sleep on this. So these are the events, the journal Sleep. Dr. Stuart Min, myself, others showed the results in 20 patients, events per hour pre and post treatment. So you can see that most patients, jaw forward got them a lot better. But what the heck? We've got some that look like the AHI events per hour goes up. And that sort of alarmed us, like, why are some patients getting worse with an oral appliance? And it drove home the notion that, yeah, you have to absolutely follow these patients and do a home sleep test or some kind of, these were all PSGs, by the way. So it was kind of a big deal at the time. This is 1996. So early on, kind of some really good results. Now, if we look at a study, and this is one of my favorites, Walter Reed Hospital, the sleep clinic. This is one of my favorite studies to look at because it was a big N. We've got almost 500 patients, a mean AHI of 30. So we're talking about pretty severe patients. So we had a whole bunch of patients. In a sense, they were, the study's a little biased because everyone was ordered to participate. But I think besides that, it was a well-done study, very thorough. So the MRD, mandibular repositioning device, reduced the AHI to less than 5. And you see the numbers here, 70% in mild, almost 50% in moderate, and less in severe. So this was always the cutoff that we used for CPAP, always. And there's really no rhyme or reason for an AHI below 5, except that's what some group of guys and gals decided to apply to a successful outcome with CPAP. So as we tried to measure up to those same outcomes, we didn't succeed a lot. But however, later on, we decided that 10 was a good cutoff as well. If you go, your AHI is below 10, you have very, very little cardiovascular morbidity involved. So, and the surgeons like to use 15. But we're using 10 as a cutoff, and you can see how the results improve. Now, CPAP is always effective. Why? Well, you've got an effective way to blow open the pharynx with positive pressure, basically. So this is the most effective treatment available, and I totally am supportive of CPAP. But why? Well, it blows open the pharynx. Now, this is the this is the view that many patients have of CPAP. And I don't know if you've seen the movie Aliens. That was the movie. You know, this is the way a lot of patients see CPAP. So I get lots of patients that can't use the mask, can't adapt, can't use the mask well. It's a beautiful treatment, but it's hard to use sometimes for some patients. Now, what are we trying to do? We're really just trying to overcome a natural consequence of sleep, which is you fall asleep, muscles relax, and that includes the tongue and the pharyngeal muscles. So as the tongue slides back, the airway closes, and we have flow resistance. I mean, that's the bottom line. It's very simple, actually. If you hold the chin forward, we can improve the caliber of the space back behind the tongue. You can blow it forward, you can pull it forward with a jaw advancement device, or maybe surgery or some other technique. Especially now we have the lingual nerve stimulator available too. So what we're trying to do basically is move the tongue forward off the back of the throat. Airway issues improve, the airway caliber improves, and it affects the soft palate, nasopharynx, oropharynx. When you move the tongue forward, the soft palate moves with it. There's a palatal glossus muscle that will move that soft palate forward. Nasal breathing improves many times, most of the time, and things get better. So what are the basics here? Let's take a step back. Oral appliances can make the patient worse, and we wonder why. Well, we look at the metric apnea-hypopnea index, and we say, is it better to have an apnea or hypopnea? And when we see patients that come back with, as I showed you in the prior study, maybe a little bit better, usually, but sometimes the AHI increases, and so we wonder why. But if you actually dissect the data, you see that hypopneas increased. Apneas went down, hypopneas increased. And if you look over to the hypoxia side of the report, you see overall hypoxic burden improved. So we've got sort of a dilemma where we go like, okay, why do you feel better even though your AHI went up? And this was very common for a long time for me. Like, what the heck? You know, let's figure this out. Turned out that the hypoxic burden improved, and then AHI may go up, but patients are feeling better. So I know this is clutching at this concept is tough for some physicians, but when you improve hypoxic burden, patients feel better. Okay, so let's look at some more stuff. We only have a little bit of time. So phenotyping, this is one of the issues that we've had for years and years. And I boil it down to, hey, two things. Really, there's awake and sleep. Awake, our muscles work. You know, our pharynx dilates with each breath, cooperates with the diaphragm. Everything's wonderful awake. But when you lose muscle tone or lay on your back, you're going to lose airway caliber. So is it due to a container issue, which is the throat, oral cavity, or are you just overweight? You've got too much stuff in there. And this is Joe the Fat Boy from Charles Dickens. And he was a wonderful writer, but he wrote about Joe the Fat Boy who was somnolent and could hardly stay awake. And so the typical presentation for sleep apnea was always considered to be obesity. But now we understand maybe it's the size of the bony enclosure. Okay, so when you see a patient that has a high palate, narrow across the palate, that's less of a garage for the tongue. And so you're going to have a disparity for airway size because of the inadequacy of the tongue space, if it makes sense to everyone. All right, and then along comes Dr. Schwab, Richard Schwab. He's out of Penn, and he did a lot of work with, MRI. And of course, this is expensive, and we can't do it much. But he saw, how about this patient who tends to deposit more fat in the tongue than this guy? So normal subject, apneic subject, same BMI, if you'll notice, 59.1 events per hour versus 10. Tongue volumes are different. Tongue fat percentage, okay? So he created a concept that, some people are going to deposit fat in their tongues. So I like to talk to patients, say the tongue is a cork, and that some people are going to have bigger corks than others. And that sounds kind of silly, I guess, but it's true. When Richard showed this, it was remarkable. And so it explained a lot why the same BMI might show apnea and some will not. Okay? So how do oral appliances work? Well, if you look at mandibular advancement, I'm going to put this over here a little bit more. There we go. What we see when the jaw came forward on cone beam imaging is that the airway, previously this big, mostly widens laterally. And that was a big surprise for us. We thought it was anterior, posterior AP change was probably the biggest thing, and we see some of that here. But mostly we see lateral change in the airway size, the lumen. So if the jaw comes forward and we're chitting that patient and putting him in a hammock, probably the theory is that we're decompressing the pharyngeal tissues. Okay, so this is the primary mechanism of action of the oral appliance. Now, there's something else I need to mention, because the original oral appliance was a tongue retaining device. So this is a modern one. We used to construct them with custom stuff, measure the tongue, build a bulb. The original one was made out of beeswax, believe it or not, and it was invented by a psychiatrist, Dr. Samuelson, way back. But now we have pre-made ones. You can see, you squeeze the bulb, put your tongue in, squeeze the bulb, and your tongue is held forward. And they work very well. They work very, very well. And we don't prescribe them a lot because your tongue will fall out, and this doesn't look very sexy. So most people will go with the jaw advancement. But again, now we're here at Sutherland. This is Richard Schwab's group. You can see the differences between baseline, airway space, mandibular advancement, and tongue stabilizing device, they call it here. And you can see the differences in the airway change with each treatment. So all three of these, both of these work, okay? But the problem is, if we look at everyone that's walking down this street in New York, who has sleep apnea and who doesn't, and also who's going to adapt to an oral appliance or CPAP, and we really still don't have a firm handle on that. Here's what I know for sure. And this is done, I don't have a date on here, but it's a long time ago. Kushida Cleet, who is a big name in the sleep community, showed that the distance between the upper molars, when it's narrow, you can pile that into a formula and predict sleep apnea. Normally, this distance should be 38 to 42. When you're narrow, your garage is too small, and your tongue's going to be retro-positioned. That's kind of the basis for this formula right here. So early on, we understood that, if you have a narrow palate, then you're going to have less room for the tongue. So one way to think about that that's really fast for a busy physician is looking at tongue scalloping on the tongue. Tooth scalloping on the tongue. And that's seen right here. As soon as you see that, you understand that there is not a lot of parking room for the tongue, and we have a narrow palate. Okay? And Weiss did this study, and he saw tongue scalloping 81% positive predictive of OSA. So is it the size of the tongue? I've had lots of doctors say, oh, he's got macroglossia. Well, macroglossia is a congenital abnormality. It's not, this is not macroglossia. It's a small container. So be careful about that as well. Now, I'm moving on quickly because I don't have a lot of time. We're doing a lot of cone beam imaging and looking at the airway. Okay, so in this gentleman, I got a profile view of him and also his palatal width. He had teeth extracted and orthodontics done, headgear, all kinds of cool stuff that probably changed his diameter in here. But his tongue is positioned back because there's not a lot of room to get up inside this palate. So we can see that his soft palate right here, hard palate is bone, profile out here, front teeth. So he is a typical kind of flat profile. For a dentist, that means, okay, right away, I walk through town and I see people and say, oh, you have sleep apnea. And it's kind of weird. It's kind of like the seventh sense where I just walk around and tell that you have sleep apnea, sir. But what can you do? Now, there's other reasons for sleep apnea too. You can have giant tonsils. You can have, moany growths in the floor of your mouth called tori. Things like that also crowd the airway. So you have to look in the mouth and figure out a narrow palate is where it starts, right? This is pretty narrow. So this patient is in a lot of distress. Okay, so here we are with, I want to go over how we make appliances and what we're using these days. So I showed you the monoblock piece. That's kind of antiquated, but when they go in the mouth, they kind of look the same. These new materials, this is called a micro 2. Here's the material, and it's quite strong, quite clear, stays nice. We've got these wings that clutch together so the lower jaw can't fall back. Okay, we have other ones with attachments front to back, top to bottom, if you will. We have anterior screws. You can stick a driver in here and turn it and advance the jaw. We have elastic connections. I mean, basically, all of these devices work the same way. We're going to hold the chin forward. What's changed is the technology where we have micro screws and we actually now scan the teeth and we can digitally create devices. This one's called a Panthera. It's made out of a nylon material. It's super thin and it's a great device. And we use these scanners now to just sweep around the mouth, and instead of impressions, the mud they call it, we can just sweep around and get a digital impression of the teeth. So the technology is advancing, but it remains the same basically. So the last thing I want to touch on. All right, so if we aim at the palate not being wide enough, why don't we just widen the palate as a treatment option? So here's a typical person, they're missing bicuspids, they had orthodontics, headgear. Why not widen their palate, create a better garage? Okay, and this is called the Daynight appliance, DNA. What we're trying to do is just reclaim some of the rooms. So there's a split this way and this way, and there are sutures running along the maxilla that we can activate and create some stimulation of stem cells and grow bone. And these screws right here, as you turn them in the direction of the arrow, the patient does this too. You can widen and create horizontal growth in the palate. So I'm very excited about this. I mention it because it's probably the coolest thing that's come along for a long, long time. And you just wear this retainer, as you might call it, about 12 hours a day. There's a little roller ball back here to get the tongue up, accommodating to a higher position in the palate. So there's elements here, little stimulating coils in the front that kind of vibrate the front teeth, and a stretching of the sutures, and we get bony growth. And this is pretty cool because what we see on a cone beam is the widening of the airway. This is only, 15 months of treatment, widening the palate. We're talking about probably 3 to 5, 6 millimeters wider, but look what happens to the airway. It remodels. So I'm very, very excited about this. The originator of this technology was Dr. Singh, Dave Singh. And the last thing I'll talk about is, and by the way, let me just say, this is my go-to choice for a patient who's younger and a permanent fix on their apnea. You can wear a CPAP the rest of your life. You can wear a mandibular repositioner, or we can remodel the airway. So I'm really liking this treatment option for patients. Okay, last thing, insurance. Insurance coverage, Medicare, yes, check. Medicare will cover oral appliance therapy. Most insurance carriers will as well. Some insurance carriers require a trial of CPAP or other things before they'll cover an oral appliance. Okay, and that's okay because you got to try the tried and true approach to sleep apnea, and then if you fail, then they will get you an oral appliance. But almost all insurance carriers, including TRICARE, will cover oral appliance therapy. The average out-of-pocket is somewhere in the hundreds of dollars for the appliances. So it's kind of reasonable. The thing with CPAP is probably no cost for the patient out of pocket, and because the DME carriers don't charge those copays sometimes. But we're talking about a few $100s out of pocket for a patient. And all this needs a lot of skill and care, and a team that knows how to bill medical insurance, not dental. This is medical insurance, and it's not easy to do. So most dentists don't bother to try and bill medical insurance. It takes some skill. So with that said, that's kind of the end of my talk. I welcome questions from the audience now. I'm going to hang around and try and answer your questions. I know I rushed through all this. Again, thank you for the invitation to speak today. I just tried to paint a big picture on oral appliance therapy, what it is, how it works. We have some solid, proof and data and literature that shows it works. And anyway, I'll welcome any questions now. Thank you very much.